Hello everyone, welcome to your lecture on implementation, which is the fourth step of the nursing process. These are the learning objectives that we will be covering in this lecture. Once again, that's implementation. What is implementation? The step of implementation begins after you develop a patient's plan of care. So you've done your assessment, you've come up with your you've analyzed the information, you've decided on the nursing diagnoses, you've decided on outcomes that you're going to achieve, and then you've planned your interventions, and now it's time to put that into action. This is the action phase. A nursing intervention, like we mentioned, is any treatment based on clinical judgment and knowledge that a nurse performs to enhance patient outcomes, right? This is your action. The emphasis is on doing. It involves direct or indirect interventions. You have your direct interaction with the patient or indirect. It has to be within your scope of practice. Always, you never do interventions that are not within your scope of practice. Then you have to prepare for your implementation. Make sure you gather your supplies, you get ready, you make sure you're competent enough to do it. If you don't know how to do it, learn how to do it or get help from an experienced nurse who knows how to do it. Then perform the action or delegate planned interventions. There might be some interventions that you can delegate to your assistive personnel. Then carry out the care plan and then document your nursing actions. And as we mentioned, direct care interventions are treatments nurses provide through interactions with patients. For example, a patient receives a direct care intervention in the form of medication administration, inserting a urinary catheter, or discharge instructions. So these are all, you just have to make sure that they're all within your scope of practice. These are the different types of nursing interventions. We talked about this in the previous lecture. You have direct, indirect, independent, where the nurse is licensed to perform these interventions. Dependent, you need a prescription from a doctor for this. Collaborative, when you carry out an intervention with a team of other healthcare members. And then you have standing orders, care bundles, and critical care pathways. These are the different qualities you need and components of critical thinking that you need in order to implement your interventions. Think before you act. This is extremely, extremely important. Review the set of all possible nursing interventions for the patient's problem. Make sure you do a thorough research, use evidence-based interventions. Review all possible consequences associated with each possible nursing action. So every intervention that you perform or every action that you take is going to have a consequence. Make sure you review those properly. Right? Determine the probability of all possible consequences. What is the probability that the patient will improve or not improve or deteriorate? Think about all that first. Think before you act. Judge the value of the consequences to the patient. That's also very important. Implementing nursing interventions is very complex. Proper preparation for implementation ensures efficient, safe, and effective nursing care. Patients often experience adverse events when nurses do not adequately prepare. So when you don't think before you act, a lot of times that happens, and we have adverse events. The Agency of Healthcare Research and Quality identifies 3 categories of adverse events. One is preventable adverse events, those that occur due to error or failure to apply an accepted strategy or prevention. So you did not apply the right intervention. It wasn't accepted, it wasn't reliable. Then we have ameliorable adverse events. Those that, while they're not preventable, could have caused less harm if it was done differently. And that's an important aspect of it too, whatever intervention you do, yes, maybe there was going to be harm, but the harm would have been less if you did it differently. Adverse events due to negligence. These are those that occur due to care that falls below the standards of expected clinicians. So an average clinician, what would a reasonable clinician do in that situation. If it falls below that standards, then it's considered negligence. How can we avoid these adverse events, right? When you're conducting your intervention, always reassess the patient. For example, if the patient was in a lot of pain, the doctor ordered a pain medication, you decided, okay, acute pain is your nursing diagnosis, your intervention was to administer analgesics, and your outcome was that the patient will have pain less than 3, and then you gave the medication, reassess the patient. Frequently reassess the patient. Go check on them, because maybe that they had a reaction to that analgesic, and instead of their pain going down, they had respiratory failure and went unresponsive. So it's extremely important to reassess your patient. Review and revise the nursing care plan based on the patient's current situation. For example, if the patient's pain got reduced and your intervention worked really good, revise the data, diagnoses and interventions and evaluation. Revise everything so it's current and up to date. Prepare for your implementation. Gather all your supplies. For example, if your intervention was to insert a urinary catheter, make sure you gather all your supplies. Keep an extra kit on hand just in case something goes wrong. And don't open everything, because then if you don't need to use it, then it's a waste. It's not a good thing to waste resources either. Anticipate and prevent complications. So when you're performing your intervention, anticipate a complication. Okay, what if this happened? What would I do? Be prepared for it, right? And then implement the intervention correctly. Use the correct procedure. Do it correctly. And if you don't know how to do it, and a lot of times new nurses do not know how to do things, and that's okay. You ask somebody, you consult with another nurse who's experienced, and they can guide you. Reassessing the patient and reviewing and revising the care plan. How do we do that? As we mentioned before, assessment is a continuous process that occurs each time you interact with the patient. Every time you meet the patient, you assess them. It involves the collection of new data. Reassessment is not the same as repeating the previous assessment to evaluate care or determine a patient's response to an intervention. Instead, it's gathering of additional information to ensure that the plan of care is still complete, current, and appropriate. When you collect the new data about that patient, you sometimes identify a new nursing diagnosis or determine that additional interventions might be necessary for not only that new diagnosis, but also an existing one. So assessment is just a continuous cycle. Revise the data, update the care plan so other team members see the changes. Revise your nursing diagnoses and outcomes. If you need another nursing diagnosis, add it in there. If one of the nursing diagnoses you feel is not appropriate, take it out. But you have to repeat that cycle all over again. Select and revise interventions that correspond to your new diagnosis, right? So whatever diagnosis, say for example, you thought the patient was hurting because of, your diagnosis, was acute pain, and then you realize it's more of anxiety and not pain, then you have to change your nursing diagnosis. And if you change your nursing diagnosis, whatever outcomes and interventions you planned, those will change along with the nursing diagnoses. Then choose the new methods of evaluation. Then you have to decide, okay, how will I evaluate this? Preparing for your implementation. Manage your time, physical, psychological, sociological, everything. Just manage your time. Equipment. Decide on the supplies you need. Keep them accessible. Keep an extra on hand, as I mentioned. Return unused open items. Personnel. Delegate. Whenever you can delegate and it's within the scope of the person you're delegating it to, delegate some things. You might want to delegate a set of vital signs to your, assistive personnel, right? Then the environment. Make sure the environment is safe and conducive to care. The environment influences the ability of the nurse to deliver interventions and the ability of the patients to heal and recover. Patient safety is your first concern. So if a patient has sensory deficits, physical disabilities, or an alteration in the level of consciousness, it is especially important to arrange an environment to prevent injuries. So make sure the environment is safe. Patient. Prepare the patient physically and psychologically. Make sure the patients are prepared. Relieve any physical symptoms and provide emotional support if they have psychological concerns. Delegation. Let's briefly talk about delegation. Delegation takes place when the RN who holds authority for nursing care delivery transfers the responsibility for the performance of that task to an unlicensed assistive personnel while retaining accountability for a safe outcome. So when the UAP accepts that responsibility for the delegated task, they have the authority to complete it as you direct them, though, right? So as an RN, you will frequently delegate patient care and activities to licensed vocational like LPNs and UAPs. Assigning is not the same as delegation. Assigning is when you assign a task to somebody, then the accountability for that intervention also transfers. So if I assign something to another nurse or to an LPN or to a UAP, then the accountability transfers to them as well. But if I delegate, the responsibility is still on me as the registered nurse. So how do we anticipate and prevent those complications we mentioned? Remember, you're performing the intervention. You want to, make sure that there were no adverse events. So you assess thoroughly, recognize risks, adapt interventions, assess benefits, implement risk prevention measures. For example, if you know the patient is a fall risk, implement fall prevention measures. Identify complications that can occur. Be aware of potential complication. Identify areas of assistance and ask for help or delegate. What are the skills that we need to implement? Nursing practice requires cognitive, interpersonal, psychomotor skills as you implement direct and indirect nursing interventions. You apply the appropriate skill to the procedure you perform. Sometimes this requires a mix of skills and good judgment. So cognitive skills is where clinical judgment using critical thinking involves cognitive skills. During implementation, you apply these skills to ensure that no nursing action is automatic, but instead it is thoughtful and patient-centered. Carefully consider each clinical situation. A cognitive skill involves knowing the rationale for the intervention and understanding normal and abnormal physiological and psychological responses. Interpersonal communication is essential for nursing interventions. Apply interpersonal communication skills by developing trusting relationships, expressing caring, and communicating clearly with patients and families. Active listening. Patients want you to hear their stories. Often they share this information that is not only useful for assessment, but also is helpful in knowing how best to deliver that intervention to the patient. Then we have psychomotor skills. Psychomotor skills require integration of cognitive and motor skills, both, right? For example, when giving an injection, you need to understand the anatomy and pharmacology, which is cognitive, and use good coordination and precision to administer the injection correctly, which is a motor skill. So with time and practice, you learn to perform skills correctly, smoothly, and confidently. All three of these are very, very important. Direct care, as we mentioned before, are activities of daily living, instrumental activities of daily living. Then we have physical care techniques, life-saving measures, counseling, teaching, controlling for adverse reactions, and preventative interventions. All these are a part of direct care, where you're directly interacting with the patient. Some education tips, because, education is also a direct intervention. Delegate more to make time for patient education. Delegate the simple tasks that you can delegate and are within the scope of the UAP. Educate every time you meet the patient. Correct any misinformation given. For example, if you explain something to the patient and it was incorrect, go back and let them know, hey, I'm sorry, this was incorrect. This is how we do it. The patient will learn to trust you that way, right? And use layman's term, common plain language. Use visual and audio materials as needed. Use the teach-back method. Teach them and constantly ask them questions about it to see if they understood. If it's a skill you're teaching them, for example, you're teaching them how to take an insulin injection, use the return demonstration method where you teach them once and then you let them do it as you watch them and they're explained to you as they do it. Let patients explain step by step. Repeat education as needed. Provide patient with information about signs and symptoms that they need to report to the healthcare provider that are urgent, after discharge. Indirect care is documentation, delegating, supervising, medical order transcript. When the doctor gives you an order, you're putting the order into the computer. That's indirect care. Infection control, you're making sure the room is clean. You're making sure the signs for the isolation precautions are up. All that is indirect care. Environmental safety management, making sure the room is free of clutter. Make sure the patient has the call light. Making sure all these things are there. That's also indirect care. Telephone consultations, when you need to consult, another healthcare provider, a respiratory therapist, a wound care nurse. All of that is indirect care. Handoff reports, when you're giving SBAR to another nurse for the oncoming shift, that's also considered indirect care because it's still about the patient. Collecting, labeling, and transporting specimen, even a simple thing as after you collect the blood work, you're labeling the tubes, that's considered indirect care. Transporting patients to procedures, like for example to IR for a CT or MRI, then you're still providing indirect care. Achieving patient outcomes and patient adherence. Patient adherence is a very crucial factor in healthcare. Most problems that patients have, the reason for why they return back to the hospital and our readmission is because of lack of adherence. Patient adherence means when patients and families invest time in carrying out the required healthcare treatments. So if the physician requires that, okay, this is ABC, this is what you need to do after you discharge, adherence is when the patient does it. Right? And they invest time into doing it. It requires willingness from the patient to implement that. For example, taking their medications every day. They need to be willing to do that. And the persistence, continually doing it, to take that medication. The interventions that we as nurses can do to promote adherence include education, providing education that's individualized to the patient. Please don't just print information, general information, and just go there and start reading it off the paper. It has to be individualized for that patient, based on your assessments of that patient. Technical skills, simplify the drug regimen, the drugs that they have, the medications that they have to take, and packaging and pill organizer. Teach them about that. Show them how they can organize their medications into the pill organizers and stuff to make it easy for them to take medications when they get home, especially for our older adults. Interventions to provide adequate and timely discharge planning, collaborating with the patient and family. A lot of times nurses do discharge teaching right before the patient is discharging. Oh, they're discharging, the order is in, the patient is leaving in an hour, so you run in the room and you're like rushing through discharge information. That's the worst thing you can do. Discharge education should start at the time of admission. That's when discharge planning starts. You start teaching the patient at every encounter and get them prepared for discharge. Behavioral, I skipped that one. Memory aids and reminders. Teach them, hey, you can put reminders, their app. You can teach them about different apps that they can use to remind them to take their medications. Reinforcing and, the treatment plan with the patient to encourage patients to follow the plan of care. Interventions should reflect the patient's health beliefs, culture, lifestyle pattern, and patterns of wellness. Always consider that. And remember, when the patient first got admitted and you did your assessment, you collect all that information and you provide discharge teaching that takes into consideration all those things. And that is it for implementation. The next one will be evaluation.